So what is the shock? So this is the only introduction. So the definition there is next slides. So shock is a physiologic event with many different causes, but if it's untreated, it has a single clinical outcome. So all the patient, if you don't treat them, they will end by death. The mortality rate in the shock overall, 20% of patients who got shock, they got dead. So that's why we need to take care of any patient with a sign of shock. We ask before shocks happen, just to make sure and make ourselves ready for shock. So that's why in each clinic, in each department, each emergency, we have the emergency trolley ready for shock. So this is all the definition from the textbook from Billy Love, Davidson, Schwartz, Kumar. So all the same meaning. What is the shock? The definition. So shock is a life-threatening situation due to poor tissue perfusion. There's no blood or no oxygen coming from the blood to supply the cells. So that's why we get impairment of the cellular metabolism manifested by serious pathophysiological outcomes. All the definitions, they have the same meaning, just for you to read it if you need more details. So why shock is important? Why shock is dangerous and associated with a high rate of mortality? So generally, it's life-threatening clinical syndrome of cardiovascular collapse is characterized by what? Acute reduction of effective circulating blood volume, so which we call it hypotension due to hypovolemic shock, or an inadequate perfusion of the cell. Sometimes we don't have hypotension, we have good intravascular blood volume, but there is poor perfusion of the blood to the cells level and the tissue, can lead to hypoperfusion. So if uncompensated is not corrected, because the body pathophysiology can compensate and try to keep the body as a normal parameter, but sometimes the bodies fail after several minutes. So that's why we need to treat it acutely according to the shock type, and this mechanism may lead to impair the cellular metabolism and the death. So the clinical manifestation of the shock patient is motivated by two mechanisms in the body. So sympathetic and neuroendocrine stress response, which lead to inadequate oxygen delivery and end organ failure dysfunction and can lead to death. So what is the classification of the shock? We have primary shock, which is the initial shock. The shock happened first time and usually due to hypovolemic shock. And we have the secondary shock, which we call it true shock. So true shock is circulatory imbalance between the oxygen supply and the oxygen requirement. So usually we have oxygen supplies going through the blood and oxygen requirement from the cells. So sometimes, most of the time, sometime of the shock. So we have good blood supply, but there is impaired oxygenation in the blood itself can lead to shock. That's why we call it circulatory shock, the secondary shock. And we have the third time, the anaphylactic shock. So what we are going to see, guys, in your clinic more, anaphylactic shock, the most common shock, you can see it in your dental clinic. I told you what kind of medication, what kind of procedure can lead to anaphylactic shock, and how can you treat it. So according to the etiology of the shock, we have sub-classification for the shock. We have hypovolemic shock. You can see it where hypovolemic shock due to decrease the volume of the blood. So in patient bleeding profusely, in trauma patient, either blunt or penetrating trauma, or post-surgery or during the operation, if the patient has bleeding uncontrolled for a long time, can get shock. So cardiogenic shock due to heart infarction or any acute attack in the cardiac muscles, decrease the blood supply to the muscle, affect the contractility of the heart itself, leading to shock, and decrease the blood supply to the tissue and level of the cells. So septic shock, we saw it in which kind of patient? Usually immunocompromised patient. So patient sick or patient have wound sepsis, bacterial infection. So let's see, patient diabetic food, have very badly infected diabetic food, can get septic shock. So that's why we need to control the source of the shock, treat the bacteria infection to treat the shock before. So the other subtype, we have traumatic shock, we have neurogenic shock, we have hypoadrenal shock. We're going to talk about all of them in details, each one alone. So according to the flow of the blood also, so we have subclassification due to low volume, reduce the stroke volume of the blood, intravascular volume of the blood. So we have the hypovolemic shock, cardiogenic shock, and obstructive shock. So due to the low peripheral arterial resistance, which means there is good intravascular blood volume, there is good blood inside the blood vessels, but blood vessels is dilated. So that's mean if you compare it, so which means there is low blood inside the blood vessels and decrease the blood pressure. So usually we saw it in septic shock, anaphylactic shock, and neurogenic shock. And we have another name for these three groups we call distributive shock. So this is the other subtype, also kind of shock. So most of them we talk about it. So we're going to say it again also. So vasovagal shock is a subtype of neurogenic shock. If you watch UFC fighting games, so sometimes due to single kick in the jaw or in the neck, so the player get collapsed on the floor. So vasovagal shock, due to vasovagal shock. Psychogenic shock, also some kind of sub kind of neurogenic shock. Neurogenic shock usually we see it in patients with spinal cord injury. Any patient have spinal cord injury with paraplegia, quadriplegia, whatever, and sometimes during also just only hematoma around the spinal cord can get neurogenic shock due to effect of the sympathetic supply nervous system to the blood vessels itself. So hypovolemic shock, traumatic shock, burn can lead to shock, big surface area of the burn can lead to the shock also. Cardiogenic shock, we talk about it, and septic shock, and anaphylactic shock due to endotoxins. It's another classification of shock also. We talked about it. All of them we talk about it. Number four, we say distributive shock. To increase the distribution of the blood inside the blood vessels itself, and we talked about it. So this one also we talk about it. So what is the pathophysiology of the shock? Why we are worried about patient with the shock? Why all the patient with the shock they got death if we don't treat it seriously? So usually hypovolemic shock can lead to effective increase the circulating blood inside volume inside the blood vessels. So if you decrease the blood inside the blood vessel, that means you decrease the venous blood return to the heart, which means the heart is not going to pump and the stroke volume is going to decrease from the heart. There is no more blood is going to the lung or to the other organ of the body. So which mean by total decrease the blood flow all over the body. So decrease the blood flow mean decrease the oxygen delivered to the other tissues and organ of the body, lead to anoxia, and convert the aerobic metabolism to anaerobic metabolism, and increase metabolic acidosis in the patient, which lead to organ failure. And the body of the human body is not going to compensate, and shock happen. Once shock is happened, so you reach the 20% of mortality, which means patient is going to be die within minutes if you're not treating the patient. So hypovolemic shock, as we mentioned it before, so due to hemorrhage, and usually most of them due to trauma. So in our country, we're talking about the blunt trauma, the motor vehicle accident, the most common and most common cause of shock is intra-abdominal solid organ injury, which means spleen number one, splenic rupture, or hepatic rupture. Second most common, thoracic cavity injury due to rib fracture can give you big amount of hemorrhage inside the chest cavity and lead to shock. Burn, very big wide surface area of the body. If it gets burned, you lose a lot of fluid and lead to dehydration. So dehydration itself can lead to shock, where we saw the patient with dehydration and shock, patient with aggressive and severe for long time vomiting and diarrhea. So septic shock due to any wound infection or any intra-abdominal wound infection or sepsis, usually due to two kind of organism. We have more special kind of organism, but the most common two, the gram-negative septicemia and gram-positive septicemia, can lead to septic shock because those kind of bacteria release some toxins to make a storm inside the body and initiate the shock. So cardiogenic shock, as we said, due to the heart infarction, due to myocardial infarction, which lead to decrease the contractility of the heart itself and decrease the cardiac output, and generally overall the body decrease the blood flow in the body. أمجد موجود؟ معلش شبيبة، من عنده المايك مفتوح؟ تسمعوا الصوت؟ طيب واحد يفتح الصوت سواء بنت أو ولد. حد يفتح المايك. ايه، واحد منكم يفتح المايك.
السلام عليكم.
وعليكم السلام. منو معايا؟
عبد العزيز علي الحزمي.
عبد العزيز، معلش بسألك عن نيابة عنهم كلهم. أنا ما أدري كيف أنتم في كلية الأسنان، أشرحوا لكم بالعربي ولا بالإنجليزي؟
في دكاترة يشرحون بالإنجليزي، في دكاترة يشرحون بالعربي.
طيب مواضيع هاي أنتم تغطوها في الأسنان يعني بشكل عام، زي جنرال ميديكال توبيك، سيرجيكال توبيك، بعيد عن الدنتست توبيك، تفهموا عليها ولا ما تفهموا؟ الباثوفيسيولوجي بيزك فاهمين أنتم إيش اللي أقوله ولا ما أنتم فاهمين؟
في بعضهم مراجعين وفاهمين، في بعضهم يعني متوسط يعني الفهم في هذا الأشياء.
كويس، يعني بالطريقة اللي أنا أقرأ فيها فاهمين إيش اللي أقوله ولا أركز على شيء معين؟
يعني حاول يعني تفهمنا زيادة
طيب
يعني عشان يكون الكل فاهمين.
طيب حلو، معناته أفهمكم زيادة، معناته أدخل لكم شوية عربي، يعني ما أحب أشرح بالعربي.
ايوه، يعني مثلا الاشياء البيزك يعني ممكن نسيناها فحاول يعني تشرحها لنا لو سمحت.
طيب تمام، حاضر.
شكرا يا دكتور.
تمام، عفوا. طيب in general guys, so what I'm going to talk about, so most of the questions for your exam, the topic as all is very important topic. You are not going to face this topic again. ما راح يمر عليكم التوبيك هذا مرة ثانية، أنا متأكد من هذا الشيء. فالتوبيك هذا في حياتكم العملية كلها في الكلينيك، أنت ما حد بيجي يشرح لك شوك بعد كذا، لازم تعرف how to diagnose patient with shock أو which kind of shock, which kind of treatment. تمام. في الغالب التريتمنت هو كله بيز على ABC تبع الاي بي اس وتبع الاي تي ال اس، البيزك لايف سبورت، والاي تي ال اس ادفانس تروما لايف سبورت تبع السيرجري والميديكال سكول نفسه. هذا لو ضبطته انت تعرف تعالج الشك وغير الشك. لكن بنراجع الان الشيء المهم، بنشوف ايش الموست كومن كايند اوف شوك، الباثوفيسيولوجي فور ايتش one وهاو تو افويد ات. طبعا في غالب الظن most common question in the exam ما راح تيجيكم question direct من slides. So information in the slide is only for your baseline of knowledge. So راح يجيكم clinical scenario، يعني راح يقول لكم مثلا patient 35 year old got stabbed in the chest واللي عنده تروما في الابدومين وجاي shocked، patient unresponsive، blood pressure is low، tachycardiac، heart rate عالي. تمام، ايش بتسوي الان؟ هذا معناته patient عنده bleeding، patient shock، what are you going to do next? So you need to know how to approach patient with shock. So I'm going to tell you how to approach patient once we reach the shock subtype. Okay, stage of the shock، مراحل الشوك كيف تحصل. So deterioration of circulation shock is progressive and continuous phenomenon. Compensatory mechanism become progressive and less effective. ايش مفهوم الكلام هذا؟ once you have patient with shock، يعني جاك patient الان عنده shock clinically how can I diagnose patient with shock؟ يكون عنده low blood pressure، tachycardia. الهارت ليش يحصل فيه tachycardia؟ لانه الهارت يعمل شيء اسمه compensation، يحاول يعوض الانترافاسكولار فوليوم، سواء البيشنت المريض كان عنده شيء ونزف زياده، او عنده نزيف داخلي، او عنده انافلاكتيك شوك. انافلاكتيك شوك هذه ما فيها اي نزيف، يكون في هايبوتنشن، كل الاوعيه الدمويه يحصل فيها دايليتيشن. عشان ايش؟ الكيميكال اللي تفرز من داخل الجسم. فالجسم يقوم ايش؟ يعوض، الميكانيزم كومبنسيشن، يعمل كومبنسيشن، يزيد الهارت ريت عشان يزيد ضخ الدم، ويزيد الفينس ريتين للهارت عشان يزيد الدم اللي يطلع من القلب. ف once the circulation of shock start، تمام، ما راح توقف. يعني البيشنت يحصل له deterioration، يتدهور على طول ورا بعض. في نفس الوقت الميكانيزم كومبنسيشن يزيد، والفينس ريتين يزيد، يبدا معاك يزيد يحاول يعوض، لكن لمرحله معينه ويوقف، بعدين يصير deterioration، ينزل. فعشان كذا مريض الشوك لازم اشوفها في البدايه، اعمل له assessment، start your treatment، start your management، don't waste your time. If you waste your time you're going to waste the patient. الكومبنساتوري ميكانيزم less effective، progressively less effective على المدى الطويل. لو المريض الان جاء شوك بعد ساعه بيموت، فانت خلال نص ساعه الجسم يقدر يعمل كومبنسيشن، لكن بعد كده لازم تكون انت اوريدي بادئ ميديكيشن. تمام. وات از ذا 3 ستيج اوف شوك؟ هذه نتكلم عنها في نون بروجريسيف. نون بروجريسيف ايش معناتها؟ ما ثابت. initially compensated reversible shock. Give me a second guys. Okay, so معلش شبيبه. Okay, for the first stage of shock we said non-progressive، يعني شيء ما تدهور. non-progressive initial shock تكون compensated، the body completely compensated reversible shock. يعني early patient نزف مثلا 1000 1 liter or 500 to 1 liter due to anything or small anaphylactic shock. First time you got medication gives you shock, so something reversible. Okay, so progressive decompensated shock. Progressive that means is going to be very bad, and decompensated is not compensated by the body. So الجسم اخذ وقته، اعمل compensation، ما في الان، هذا خلاص. الثالثه الاسوء يحصل ايش؟ decompensated. So خلاص human body reach a point is not going to compensate anymore، irreversible، ما راح تصلح خلاص. most usually those patients going to die. 100% this patient dead. So dead that means he's going to get heart arrest. You need to do CPR. لازم تعمل له كومبريشن CPR على اساس يرجع يعيش، وبعدين تشوف هل بيعيش معك ولا ما بيعيش. Okay, the next 3 slides all talk about the same pathophysiology of the body according to the shock. So the first one we are going to talk about it. The second 2 we are not going to talk about it because most of the diagram is the same. So non-progressive initial shock, we say the stage 1, the first stage, what's happened in the body. So blood loss of fluid redistribution due to anaphylactic shock or due to trauma, blood loss. So stimulate the vasomotor center of the medulla in the brain. So what's happened in vasomotor medulla? So activate the sympathetic response. So sympathetic response activate the heart output by increase the heart rate and contractility. Number 1, try to compensate. This is what we call compensation. So increase the peripheral vascular resistance. So بدل ما تكون الأوعية الدموية مرتخية تقبض وتكون مشدودة عشان تزيد كمية الدم داخل ويزيد كمية الدم في الفينس ريتيرن ويرجع للهارت ويزيد الكاردياك output. So all the aim of the body pathophysiology to increase the blood volume and increase the blood pressure, because most of the patients with shock they lost blood pressure. due to bleeding or due to redistribution, vasodilation of the blood vessels. Okay, this is what happened you on the sympathetic response, the first line on the left side. In the middle, what's happened in the middle? So also in the body, try to compensate by hormonal response. Hormonal response, you have two glands in your body can affect the blood pressure. So pituitary gland and adrenal gland. So pituitary gland secrete antidiuretic hormone secretion increase on the kidney, work in the kidney. So pituitary gland وين موجودة هذه؟ فوق على الجمجمة. تمام؟ تفرز ايش؟ انتي دايريتك هرمون، هذا هرمون يطلع منها ايش يسوي؟ increase kidney reabsorption for water and sodium salts. بدل ما يطلع يورين زياده يقل اليورين، السوائل اللي تطلع تنفعك فين؟ داخل البلد فيسلز. اوكي، على الادرينال جلاند ليفل، ادرينال جلاند هذا above the kidney، يحصل ايش؟ aldosterone secretion. Aldosterone also hormone secreted by the one of the three layers of the adrenal gland. So increase the same function like antidiuretic hormone, increase the water reabsorption from the kidney and the salts also, sodium and potassium. So most of those patients, they have oliguria or anuria. Patient في الشوك ايش يحصل عنده؟ urine output is very low، ما يطلع الله يكرمكم بول. ليش؟ عشان الشوك يعني الكدني تحاول تحفظ كل سوائل في الجسم وتعوض الجسم عن البلد لوس وعن ريديستريبيوشن فازودايليشن اللي حاصل. كل هذا ايمنج ليش يحصل؟ increase the blood pressure، تحصل الهارت ريت رافع، بلاد بريشر مضروب نازل، هذا كله عشان يزود السوائل. اوكي، ادرينال ريسبونس ايش يحصل في الادرينال برضه؟ third line last one on the right side، a release of epinephrine from the inside the middle layer of adrenal gland. Epinephrine we know like sympathetic effect. It's going to increase the resistance of the blood vessels, increase the blood pressure, and they have some small effect on the cardiac muscles, but increase the contractility of the heart. Okay, this is in the early stage, first stage of progressive compensated reversible shock. Initial at the beginning of the shock. If you reach the middle of the shock, the progressive decompensated shock, so there is another mechanism is happening to decrease the blood pressure and cellular hypoxia, and what's going to be happening. So if you don't have blood supply, it's going to the tissue or to the cells. What's happened to the cells? So that means there is no food, there is no oxygen going to cells. So cells usually feed on something called anaerobic aerobic metabolism. If you don't have blood and oxygen, convert to anaerobic metabolism due to decreased oxygen and the blood flow, which mean lead to increase the CO2. So if you have cellular, all of those in the second stage, you got something called cellular hypoxia, which means decrease the blood flow and the oxygen to the cells, lead to increase the carbon dioxide and convert the metabolism inside the cells to metabolic acidosis by increased respiration and increase the CO2 reproduction. So which lead to anaerobic metabolism and increase lactic acid. So all the patient with trauma, bleeding, whatever kind of shock, we do the blood test first. During the assessment patient, we check for lactic acid. So if the patient have high lactic acid, we say lactic acid acidosis, lactosis or lactic acid acidosis. So which means patient in shock, there is no blood going to the cells or the organs. So we need to support this patient with either, if the patient bleeds too much, we need to give him blood or crystalloid fluid to increase the intravascular volume. لازم تزود الانترافاسكولار فوليوم عنده وعنده نتعوض عنه. لان اللاكتيك اسيدوزيس هذا يدمر داخل كل شيء، بيدمر لي ايش؟ كدني فانكشن، blood pressure, heart, and lead to multiple organ failure. بدل ما يكون عنده single organ failure يدخل multiple organ failure. If he had multiple organ failure, this patient is going to die 100%. You're not going to save him. Okay, third stage, same thing. Everything deteriorated and more deteriorated, the patient is going to die by the end. The most important slide, the first one of all the stages, the first stage. Okay, this is the same thing, but in the timetable. So same stage, what we told about in the diagram, we put it in the table for you just to read it. Okay, what is the general clinical feature? We talk about it. If you have patient with shock, either in the clinic, during your procedure, or in the ER, on the ICU, in the ward, whatever, or even in the market, in the street. So you found patient with hypotension, which means systolic blood pressure less than 100 millimeter mercury, tachycardiac, heartbeat more than 100 per minute. From outside, the skin is cold and clammy. لما تحس على الجلد من برا تحس جسمه بارد. وعليه طبقة خفيفة من العرق يسميه كلامي مرطب. تمام. rapid shallow respiration نفسه يكون سريع وخفيف. drowsiness مدوخ. confusion ما هو واعي. irritable يضارب ويصارخ ما هو حاسس باللي حوله. ممكن إذا تأخرت عليه زيادة يصير كوماتوز كوما يدخل في غيبوبة. طيب after that ايش قلنا على اليورين اوتبوت؟ اليورين اوتبوت نورمال يورين اوتبوت 1.5 مل بير اور. سو هذا يكون ايش عنده 30 مل بير اور less than 30 مل بير اور. سو اوليجيوريا. واي اوليجيوريا؟ هذا شرحناها قلنا ليش؟ لان الكدني تراي تو كومبنسيت ذا انترافاسكولار فوليوم اللي حصل لها لوس. فايش تعمل الكدني؟ ري ابزوربشن ذا ووتر اند صوديوم. elevated and reduce the central venous pressure. It depends what kind of shock. Usually, most of the time, reduce due to the blood loss. And by the end, multi-organ failure. So the first organ failure, now how many organ failure we have in these slides? So high blood pressure and tachycardia, this is the beginning of organ failure of the cardiac system. Okay, rapid shallow breath is the organ failure of the respiratory system. Drowsiness, confusion, irritability is the failure of the central nervous system. So oliguria is the failure of urinary or kidney. So it's the most first sign, and most sign we use it to monitor those kind of patients. So if the patient have multiple organ failure, more than 2 or 3 systems, this is a very bad situation. So those kind of patients, we need to admit them in ICU or at least in high care bed. So what is the general principle of management of those patients? So a patient should be treated in ICU, in high care bed, continuous monitoring of the patient by oximetry and electrocardiography. لازم يكون في جهاز تخطيط القلب وجهاز النبض وجهاز النفس موصل على اساس تعرف كيف البارامتر كلها جايه معاه. اذا حصل له deterioration معناته there's something wrong in the management plan. Reduction of elevated, so your aim, as we say, lactic acid is very poisonous, is bad. We don't want to see high lactic acid in the blood. So also in the principle of the management, we need to reduce or reduce the elevation of the serum lactate. So level, and then we use it as a monitor for our treatment. So أنا الآن جاني مريض عنده شك، عملت لقيت اللاكتيت عنده واصل 20 after IV fluid, after blood, after oxygen and all the management. I check it after half an hour, 1 hour. I found it 10. That's mean patient is improving. So that's why we use it as a monitor for your management. Monitor for in the shock patient is the lactate. If the lactate go back to the normal range, that means you are good, you're treating the patient right. If the lactate is still going up, that means the patient is still in shock and you're not treating the patient and you're missing something. So initial assessment, as we said, guys, keep in your mind ABC. ABC of the ATLS. All the patients of shock, treat them as a trauma at ABC. So A for airway, check the airway patent, patient able to breathe by himself or no. B for breathing, patient's breathing or not breathing. If the patient's comatose, for the chest movement and check for breathing by chest movement. And C for circulation, check the vital, heart rate and blood pressure. And if there is any bleeding from outside, control the bleeding. So GCS is a Glasgow Coma Score. Any patient, so Glasgow Coma Score, we have a score, is the top score is 15. If you have 15 like me and you now, we are 15 by 15, which means we are full awake. انت صاحي الآن تتكلم وما عندك شيء. Glasgow Coma Score تبعك هذا أي واحد عنده confusion, drowsiness, irritability، واحد ما هو صاحي، سكران جاي في المستشفى، تسوي له شيء اسمه Glasgow Coma Score. So Glasgow Coma Score 15 من 15 هذا أي واحد صاحي مثلي ومثلكم. إذا أي Glasgow Coma Score أقل من 8 وأقل من 8 هذا patient need intubation. لازم تركب له endotracheal tube. intubation تحطه على ventilator. طبعا Glasgow Coma Score, you don't need to know all the details about it. We have E for I 4 points, V for verbal الكلام 5 نقاط، وM for motor الحركة 6 نقاط. لها طريقة معينة تسويها وتحسبها وتشوف. إذا جاء الكالكوليشن أقل من 8 وأقل لازم تعمل intubation, keep patient on the ventilator. This is the initial management shock patient. طبعا ممكن يجيكم سؤال في الإكزام إيش patient shock حصلته في السين في الستريت whatever in the clinic, what is the next step? ABC. Start with ABC all the time. Eh? So in trauma before, so this one, so ABC we can use it for anaphylactic shock, any kind of shock, but usually any trauma patient. So do you have a lot of trauma associated with dental injury? So maxillofacial fracture. So most of the body trauma, they have maxillofacial fracture in general, or something wrong in the mouth. So most of the time we do A, B, C, D, E. We add 2 letters also, D for disability. So disability, we do neurological deficit examination. We check for any impairment in neurological exam, and Glasgow Coma score. We talk about it. So an E for exposure, expose the patient. قطع كل الملابس اللي عليه وشوف if there is any source of deformity in the limbs. إذا في أي عظم مكسور، أي شيء، أي نزيف، تحاول تعمل له control with ABC. So what is the effect of the shock؟ هذا أطول بارت، بنقرأ على السريع لأنه أكثر تكلمنا عنه. So الإفكت تبع الشوك على كل الأورجان one by one. Cardiovascular system. shock ايش معناتها؟ there is low blood, no blood is running inside your body. ايش يحصل على الكارديوفاسكولار سيستم؟ decrease preload and afterload. ايش معنى preload؟ ايش معنى afterload؟ preload الدم اللي يرجع على الرايت سايد اوف ذا هارت يدخل ويروح الرئه وبعدين يطلع، يرجع من الرئه للافترلود اللي يطلع من الليفت سايد على الاورطه. So decrease the preload which means decrease the venous return. كل الفينوس ريتيرن اللي تروح ما في blood يقل، وديكريز الافترلود decrease البلد اللي يطلع من الهارت. Baroreceptor response. Baroreceptor response has basic of pathophysiology. ايش يحصل في الباروreceptor response؟ In the right atrium, if you have decreased the stretching of the blood inside the right atrium, so increase the baroreceptor response and increase the reabsorption of the fluid from the kidney and increase the sympathetic effect on the blood vessels. We talk about to increase blood, increase the volume inside the intravascular by increase the water retention from the kidney. So also release baroreceptor release the catecholamine, which means from the sympathetic system. So tachycardia and vasoconstriction as an effect of shock on the cardiovascular system. So on respiratory, so what we said, so we have metabolic acidosis, lactic acidosis, so we call it metabolic acidosis. What's happened during metabolic acidosis? So the lung try to compensate the metabolic acidosis. Metabolic acidosis is a bad physiologic reaction inside the body. So the lung try to compensate and converse it and make it normal. So the lung make the respiration became respiratory alkalosis. On the renal and endocrine, we talk about in the diagram also what's happening in the renal. Decrease urine output by stimulating the renin angiotensin and aldosterone from adrenal gland and release of vasopressin from the hypothalamus, resulting in vasoconstriction and increased sodium and water reabsorption from the kidney. On microvascular, on small blood vessels. So what's happening in small blood vessels? Activate of immune and coagulation system, hypoxia and acidosis. So activate the complement and prime neutrophil, oxygen-free radicals, and cytokines release. All of this is toxin, something bad happening on microvessels. Small, tiny blood vessels get very bad reaction due to shock. And all of them lead to damage of endothelium of the blood vessels, lead to leakage of the blood and fluid and plasma from the blood vessels around the blood vessel, leading to edema. Okay, on the cellular level, so we talk about it. So the cells usually use the aerobic. So if you have a shock, there is decreased blood supply and oxygen. So the cells convert to anaerobic metabolism and decrease using the ATP as a production as an energy source, which lead to increased lactic acidosis. This is all what you need to know about the cells level. So decrease the use of ATP as a production energy on the cell level, which lead to increased lactic acidosis. That's all. So carbohydrate metabolism. So lactic acidosis lactic acid lead to acidosis. Carbohydrate, if we have too much carbohydrate, lead to alkalosis. It's the basic of the pH of the blood inside the body. So in carbohydrate metabolism level, what's happening in the shock? So compensated shock, try to compensate shock by hyperglycemia due to increase the hepatic glycogenolysis. So try to compensate the body by decompensated the shock. So hypoglycemia, it can be happen due to hepatic glycogen depletion. After few minutes or few hours, the glycogen is depleted and increase the consumption of glucose by the tissue. So anaerobic glycolysis occur as a result by high blood level of lactic acids. So what you need to know about this slide, so carbohydrate metabolism tries to compensate the lactic acidosis in the body. So on the level of the protein metabolism, increase the intracellular protein metabolism and catabolism. So conversion of amino acid to urea, increase the blood non-nitrogen protein and fat metabolism, which all of them lead to death of mitochondria and death of the cells. So fat metabolism increase the endogenous fat metabolism and raise of fatty acid level in the blood. Okay, so metabolic acidosis, we talk about it. So morphologic complication. So morphologic changes in the shock are due to hypoxia, resulting in degeneration and necrosis of various organs. So all the organs get affected. So usually brain, if they have any confusion, drowsiness, that means brain is affected by hypoperfusion and lead to ischemia. So ischemia to the brain can damage the brain and neural cells within 4 minutes. If you don't have blood to the brain for 4 minutes, so you go to ischemia and the brain is going to get dead. Heart, lung, kidney, adrenal, and everywhere in your body and GIT. And each one has special manifestation due to shock. So encephalopathy, which means some sign of the coma. So we assess the encephalopathy by Glasgow Coma Score, and usually due to ischemia of the brain tissue. In the heart, in shock, you have two kinds of morphological change in the heart. So hemorrhage and necrosis. So located in subepicardial and subendocardial region. The most affected point in the heart, the most distal point, is not in the middle of the muscles, either from outside of the muscle or from inside of the muscles. You don't need to know all these details. So you need just to know that. So in the shock, heart can get acute myocardial infarction. Decrease the blood to the heart lead to acute myocardial infarction, which means تجي ذبحة صدرية لأنه ما في دم واصل ليغذي عضلة القلب. Okay, shock on the lung. So lung by itself, lung فيها 4 أو 5 blood vessel supply رايحة لها من الهارت ومن الأورطة، فما تخاف عليها، يعني الدم اللي يروح لها كثير، فما بيحصل فيها نكروسيس أو اسكيميا. لكن المشكلة يحصل فيها إيش لو صار في الشوك وديكريز بلد اللي رايح لللنج، يحصل شيء اسمه acute respiratory distress syndrome ARDS acute respiratory distress syndrome. يحصل زي inflammatory process على مستوى الالفيولاي، الساك داخل الالفيولاي، الساك الصغير اللي جاي يدخل فيها الاكسجين ويحصل له ميكس مع البلد، يحصل فيها انفلاميشن، يحصل فلويد كولكشن وانفلتريشن والفيولا هالاين ممبرين، هذه كلها تاثر على الاكسجينيشن. فتحصل المريض جالس على الاكسجين والاكسجين ساتوريشن في الدم عنده صار 40 50، لذلك لازم يكون على الفنتيليتر. So most common effective shock on the lung, remember acute respiratory distress syndrome. So shock on the kidney, we talk about shock on the kidney. The kidney is the first organ affected by shock. So kidney try to compensate and increase the intravascular volume by increase the water retention, absorption, and sodium. Started with oliguria. If the kidney became anuric, that means anuria, that means there is no urine coming out at all. Oliguria is just only small amount of urine. يعني الكدني تصفي بول خفيف، اوليجيوريا شيء خفيف، لكن انيوريا معناته زيرو، ما في شيء يطلع. هذه الكدني خلاص الان صارت اسكيميك وديث، بعد كده خلاص يصير بعد lung death, stomach death, liver death, to end by death. Adrenal shock. So what's happened to adrenal? So adrenal shows stress response. Most of the hormonal effect in the shock is raised by the adrenal gland. So it includes release of aldosterone in response of hypoxemia to the kidney, and release of glucocorticoid from the adrenal cortex and catecholamine from adrenal medulla, from the middle of the medulla. On GIT, على الجاستروintestinal system, على GIT system, what's happened? Decrease the blood supply in the shock patient. So the most inner part of the GIT is affected, endothelium, الطبقه الداخليه للجي اي تي في الاستومك في السمول باور في الكولون هي اكثر شيء يبدا فيه يحصل نيكروسيس واسكيميا، يحصل لها سلافك وتطيح، وبعدين يحصل ايش المريض يجي either something we call it cooling ulcer، تيجي ألسر قرحه من جوا فتحصل تدخل بالمضاد تحصل في المعده عنده جوه تقرحات لان الاندوثيليوم من اللي جوا طاح، ما في بلاد سبلاي يوصل يتشوك، او المريض يكون في الاي سي وعنده هيموريج بليدنج دايركت ينزل دم من تحت او يطرش دم. ليش؟ عشان نيكروسيس والميكوزا كلها ديد ما فيها بلاد سبلاي وتطيح ويصير ينزف من جوا. اوكي. liver hypoxia lead to what? Vasodepressor mediators release، يحصل vasodilation. Vasodilation then end by decrease the blood supply to the liver. Same things happen again. Necrosis of the liver. Ischemia to the liver lead to necrosis. So this diagram that show you what all the organs of the system is affected by the shock. Okay, so one of the most dangerous situations are in the shock. So ischemic reperfusion syndrome. So if you have patient in shock and you try to do reperfusion, so what is reperfusion? So let's say, so shock in general we say is a decrease of blood supply to the organ or tissue. So if you try to restore the blood supply, increase the blood supply, what's happened to the tissue? So tissue is good, decrease blood supply. If you got it for a long time, that means the tissue is going to be dead. If you increase the blood supply after a long time and tissue is already dead, so the blood is going to the dead tissue, is going to mix with all the toxins and toxin release in the body. So flush all this neutrophil with a lot of toxins inside is going to increase the shock. So you need to make sure if the patient is still responds to the treatment or not respond to the treatment, if the patient have any necrosis inside or there is no necrosis. So if you have any evidence there is gangrene, there's something dead inside, don't reperfuse the patient because he's going to die from the complications of reperfusion. So hypovolemic shock, number one, we talk about it. So occur from inadequate circulating blood volume, decrease the blood volume due to whatever the cause. So major effects are due to decrease the cardiac output. There's no blood inside the blood vessel, so decrease the cardiac output and low intercardiac pressure. So severity of clinical feature depend on the degree of the blood volume loss. So for shock itself, we have classification and subtype also. So what type of pathophysiology? Same thing we talk about, the same diagram. So I told you about this one, decrease the blood supply through the left, through the right atrium to the right ventricle, decrease the blood going to the lung, and then decrease the blood return from the lung to the left side of the atrium and left side of ventricle. So which means that there is no more blood inside the heart to pump outside to supply the body. So what is the classification of hypovolemic shock again? So we have hemorrhagic shock and non-hemorrhagic shock as hypovolemic shock. Hemorrhagic, which means bleeding, from the bleeding من نزيف. Trauma patient, any trauma إصابات سواء penetrating trauma واحد حصل له طعنة أو طلقة ونزف، أو واحد سيارة blunt trauma من الخارج، أو gastrointestinal bleeding، patient عنده esophageal varices، عنده قرحة وسببت له نزيف ونزف زيادة، أو أي سبب اللي يسبب له نزيف يعطيه hypovolemic hemorrhagic shock نسميها. non hemorrhagic shock hypovolemic ايش هي؟ external fluid loss، واحد ما يشرب ضاع في الصحراء وجالس يومين ثلاثين ما يشرب، ما في مويه يدخل، فيحصل عنده hypovolemic shock، يقل البلد inside. diarrhea, any diarrhea lead to shock, hypovolemic shock, but not hemorrhagic هذه. vomiting, polyuria, patient with diabetes, uncontrolled diabetes, he went to toilet so many times so he lose a lot of fluids and he didn't drink fluids so he got shock. And redistribution shock, which means the neurologic shock, burns, and anaphylaxis due to vasodilation. So classification of the blood loss. So which patient I need to worry if they have patient bleeding in the department, in the ER, or wherever. So we have classification for hemorrhagic shock. We have class 1, class 2, class 3, and class 4. So class 1, if the patient lose 15% of his blood volume, which means less than 1 liter. You don't need to know about the others. You need to know just only the percent and how much of the blood he lose. So if the patient lost 15% of his blood, which means less than 1 liter, if the patient lost class 2, if the patient lost from 15 to 30% of his blood, which means 1 to 1.5 liter. Class 3, if the patient lost 30 to 40% of his blood, which means 1.5 to 2 liter. Or class 4, which means the patient lose 40% of his blood, which means more than 2 liter of his blood he bleeded outside. So how many liters of blood we have in our body? We have 5 liters, most of them circulating inside the blood vessels. There's less than 2.5 liters. So most of them circulating inside your tissue, inside your cell. Hemorrhagic shock. And those kind of patients usually they bleed profusely from outside due to major blood vessels injury, which means if you have cut in the femoral artery, popliteal artery, or amputation of the arm, or stab in the neck, or intra-abdominal hemorrhage or intrathoracic hemorrhage, there's big space bleeding inside his body. It's the same timetable that we talk about it, same information, but we put it in timetable for you just to remember it. So what is the sign and symptoms of the shock? How the patient present? What is the sign and symptom? Usually patient they came in anxiety. حصل المريض خايف وما هو على بعضه وما يتكلم معاك وما هو واعي ولما يدخل في كوما. So anxiety, restless, altered mental status, and come in by coma. So hypotension decreases the blood pressure, and according to hypotension what's happened? Tachycardia. Heart rate compensate. حصل عنده heart rate عالي. Rapid and weak 3D heart rate. Heart rate عالي لكنه ضعيف لأنه ما في blood جوا. From outside the skin, cool, بارد, clammy skin, رطب. Rapid and shallow respiration, hypothermia, جسمه بارد من درجة الحرارة تلقى 35 وأقل, and thirsty and dry mouth, فم ناشف ما في fluids, and distracted look in the eye. تحسه ما يطالع لك، ما هو صاحي، يطالع فوق يطالع يمين، ما هو قادر يتكلم. هذه كلها sign of shock. So what is compensatory mechanism? We talk about it. Adrenal gland do function, kidney do function, skin do function, and everywhere. So how can we treat the patient with hemorrhagic shock? So now the most of the questions for the exam, if you got any scenario, any question about shock, just remember at the beginning, as I told you, ABC. So don't get distracted by the details of the stem of the questions. Just remember how to treat, where the question is stop, start. شوف السؤال وين وقف وايش يبغى next. في الغالب يقول لك what is the next step. So يجيك مريض عنده هيموريج ومدري ايش ومطعون ولا طلق نار وكذا كذا كذا، ايش تعمل ثاني شيء؟ يقول لك خلاص اير كويس، المريض صاحي ويتكلم وذا، خلاص معناته انا I'm not looking for the airway, I'm not looking for the breathing, I'm looking for the bleeding source. Is it control not control؟ راح اسوي bleeding source. تمام. So clinical monitoring. So monitor the blood pressure, check the respiration, check the urine output by putting the Foley's catheter. حط القسطرة وشوف الurine output, and central venous pressure. Central venous pressure is not mandatory. Usually put it in ICU, is not in the ER. If the patient's comatose or unresponsive, we can put it in the emergency room because we need a special kit, a special catheter, and special device to do the central venous pressure. So ECG, connect the patient to the monitor on ECG. Swan gas catheter, we do it only for cardiac shock, to check the cardiac output and help the cardiac to push more blood. So pulmonary edge pressure, we do it through the Swan gas catheter. So the last 2 points is not that important, something advanced for the cardiac shock. So what you need to remember, the clinical monitor, the first 5 points. So how can I diagnose a patient with the shock? So to diagnose a patient with shock, you need to know what's the cause of shock. Now how many kind of shock we have? So we have cardiac shock, we have hypovolemic shock, we have neurogenic shock. So we need to know which kind of shock, and then we need to diagnose it and treat it based on that. So cardiogenic shock, we say cardiogenic shock in which kind of patient? Usually old patient or patient with risk factor for heart attack. So مريض عنده سكر، عنده high lipidemia، smoker for long time، وجايب acute chest pain، عنده كل العلامات الحيوية، عنده جلطة في القلب وذبحة صدرية. هذا لازم يكون عنده some source of cardiogenic shock. It depends on how bad the cardiac muscle is affected. Is it small area or big area? If it's small area is fine, his body is going to compensate. But if he has a very big MI, he's going to get cardiac shock. So you need to treat this patient seriously. And most of them, unfortunately, they're going to die because the cardiac muscle infarction is not going to heal within a few hours or few days. It takes months to heal. So if you have big heart attack, he's going to die most probably. So neurogenic shock, which kind of patient we saw neurogenic shock? So usually in penetrating injury at the backbone, so gunshot to the spinal cord or stab in the spinal cord or trauma. موتور فيكل اكسيدنت، اي حادث سياره في كسر العمود الفقري، يكون في اصابه في الحبل الشوكي. ايش وظيفه الحبل الشوكي؟ يطلع منه السمباثيتك فايبر. سمباثيتك فايبر تغذي كل البلاد فيسلز، تخلي البلاد فيسل كونستريكتد عشان تنكريز ايش؟ البلاد بريشر. سو اذا ما في سمباثيتك فايبر معناته البلاد فيسلز يجي يحصل لها كلها dilatation. So dilatation of the blood vessel lead to the pooling of the blood. البلد يجمع فيها، ما تيجي تضخ البلد على فوق ويرجع للقلب. فهذا النيوروجينيك شوك. إذا بيش عنده نيوروجينيك شوك عنده different plan or different way to treat. hypovolemic shock ممكن أسهلهم، لأن أنا عندي hypovolemic هذا واحد lose blood. So إذا عنده ستاب طعنة، عنده طلقة، عنده حادث، عنده نزيف البطن، نزيف في الصدر، أنا عارف هذا عنده إصابة وعنده دم ناقص، أعوض الدم. خلاص الآن I diagnose this patient has hypovolemic shock. I need to replace it and stop the source of the bleeding. So first of all the time don't forget the ABC. Stabilize your patient. So with ABC تأكد ال airway patent. Patient breathing spontaneously. If the airway is not patent, patient is not breathing, intubate the patient, put him ventilator and stop the bleeding. How can we stop the bleeding in the chest? We put ICD, we take patient to theater for emergency surgery. In the abdomen, we take patient for surgery to control the bleeding. In the periphery, in the arm, in the legs, we put tourniquet. نحط ربطة ونربط ونوقف النزيف. لازم يوقف النزيف عشان يوقف الشوك. ونعطي في البداية crystalloid fluid, IV fluid, 2 liter maximum, and then blood. Patient lose blood, need to replace with the blood, but usually blood need time to get it from the blood bank. So we give the patient IV fluid initially, and then we do blood. In the same time, we put 2 drips, 2 IV line for drip, and we put Foley's catheter to check what? Urine output, because urine output is your monitor to check the fluid status in the body, if the patient dehydrated or not dehydrated. كيف أعرف المريض هذا نعمل resuscitation كويس ولا لا؟ من حاجتين قلنا. لاكتيك أسيد، أشوف اللاكتيك أسيد إذا كان هاي ونوت هاي، إذا ريسبونس بينزل بيرجع طبيعي، واليورين اوتبوت بيتحسن بيزيد، لأنه الكدني تحاول تعوض الجسم تحبس السوائل ما تنزل. إذا اليورين اوتبوت يطلع كويس خلاص 100 معناته المريض ما عنده شوك قوية ولا الشوك أنت عالجتها، فتحط فوليس كاتيتر عشان تعرف اليورين اوتبوت طالع. So management principle. So patient shock have low blood pressure and increased heart rate. What is our management principle? ايش تبغى تسوي انت؟ ايش تبغى تعالج؟ ابى ازود increase الكاردياك اوتبوت، ازود الكاردياك اوتبوت عشان ازود البلود inside blood vessel، increase the tissue perfusion. لو زاد البلد يزيد the tissue perfusion, which means increase the blood going to supply the tissue itself. So a plan of the action should be based on what? Primary problem. What is the cause of the shock again? Is it neurogenic? Is it hypovolemic shock? Is it anaphylactic shock? And then if you know the problem, then treat according to the problem. Adequate fluid replacement. We say we can supply the patient up to 2 liters of IV fluid, crystalloid fluid, which means normal saline or ringer lactate we give the patient. So improving the myocardial contractility either by medication, chronotropic or inotropic medication, dopamine or epinephrine to increase the contractility of the heart, or correcting the acid-base disturbance. If the patient had high lactic acid, we correct it with what? IV fluid and bicarbonate. So resuscitation, immediate control of the bleeding. We talk about it, rest pressure or packing, operative method by surgery for intra-abdominal, any bleeding in the stomach, inside the abdomen, or any bleeding in the chest. Extracellular fluid replacement by infusion of the fluid in fundamental treatment. And usually we use what, as we say, crystalloid fluid for initial resuscitation for the most form of hypovolemic shock, because those kind of patients, they lose blood, we give them a lot of fluid. Sorry guys, give me a second. Sorry guys. So after IV fluid resuscitation, so we must stabilize and restore the blood pressure. So blood pressure must go up again. So and then after that we start medication. So medication, what kind of medication do you want to give this patient? ايش تعطي medication؟ تعطي sedative. Most of the patient we say what, restless, drowsiness، ما هو صاحي وما هو واعي ويحارب ويضارب لانه ما هو في وعيه عشان low blood pressure shock. تعطي شيء اسمه sedative sedation عشان يهدى. تعطيه chronotropic agent وانوتروبيك ايجنت. ايش الفرق بين الكرونوتروبيك ايجنت والاينوتروبيك ايجنت؟ كرونوتروبيك ايجنت هذه ايجنت يشتغل على الكاردياك ماسلز، increase contractility of the heart muscles itself، يزود انقباضات القلب. اينوتروبيك ايجنت الاول زي الدوبامين، الثاني الاينوتروبيك زي الابنفرين، يزود ال contraction of the blood vessels will increase the blood pressure inside the blood vessels and increase also venous return to the heart. Okay, distributive shock. So as hypovolemic shock, there is an insufficient intravascular volume of the blood. البلد اللي جوا ناقص في distributive shock. يحصل ايش؟ ارتخاء في الاوعيه الدمويه وما في دم يطلع للقلب، فبالغالب ما في دم يروح يغذي الخلايا والاعضاء الثانيه. So this form of relative hypovolemia is a result from what dilation of the blood vessels, which diminish the systemic vascular resistance due to sympathetic effect. Example for distributive shock, we have three things. So septic shock, anaphylactic shock, and neurogenic shock. So traumatic shock, hypovolemic shock, we talk about it. Pathophysiology, the same, we talk about it again now every time we talk about. So I try to repeat most of the information, most of the slides, anytime we talk about it, just to keep it in your mind. So management we talk about. Okay, cardiogenic shock. So primary, what is the cardiogenic shock we said? So most of the cardiogenic shock due to infarction of the cardiac muscles, heart attack، ذبحة صدرية. تمام، يحصل dysfunction maybe due to myocardial infarction number 1، chronic congestive heart failure، واحد عنده ضمور في عضلة القلب ما في ضخ، سواء بسبب من بعضهم من الولادة، بعضهم عمره 30 سنة، بعضهم عمره 70 سنة، فكلهم عندهم تجون كارديوجينيك شوك. فجأة القلب خلاص يكسل ما عاد بيشتغل، فيحصل كارديوجينيك شوك اسمه كاردياك اريثميا. اذا في لخبطة في كهرباء القلب في التخطيط حيتسبب، لان هي اللي تغذي وتخلي عضلات القلب تنقبض. بالمونري امبوليزم، لو في جلطة في أوعية الرئة يزيد الضغط الدم على القلب ويسبب ايش؟ كارديوجينيك شوك. and systemic arterial hypertension، واحد عنده uncontrolled hypertension high blood، واحد عنده blood pressure 180 200 اكثر وقته ما يستخدم علاجات، يحصل شيء اسمه كارديوجينيك شوك. تخيل الهارت زي البام ماطور يضخ في انبوب، والانبوب هذا متصلب ما هو راضي يفتح. هاي بلاد بريشر معناته الانبوب مره متصلب وما يفتح، فيكون يضغط على حاجه قاسيه ما يقدر، ففجاه خلاص يتعب ويوقف، يحصل عنده شيء اسمه كارديوجينيك شوك due to systemic arterial hypertension. So what is the manifestation of dysfunction of right ventricle? Manifestation of dysfunction of left ventricle. So right ventricle معناته ايش؟ right ventricle failure معناته كل الدم اللي جاي من الجسم عن طريق الانفيرو فينا كافا سوبيرو فينا كافا يدخل في الرايت فنتريكل، القلب ما هو قادر يضخه على الرئه، فايش يحصل؟ يتراكم في نفس طريق ويرجع لورا. على وين يرجع؟ في النك. من السوبيرو فينا كافا تحصل عنده دايليتد نيك فين، النيك فين دايليتد، اكسترنال جوجرافي فين دايليتد. في البطن يحصل عنده ايش؟ هيباتوميجالي، الكبد عنده الضخم. في رجوله تحت يصير عنده ايش؟ الشيء الثالث يصير عنده بيتنج ايديما، يصير في انتفاخ وسوائل في القدم. طيب ديسفانكشن ليفت فنتريكل، الليفت فنتريكل الدم واصل لين الرئه، الجهه اليمنى في القلب تضخ الرئه، يروح الدم من الرئه ياخذ اكسجين يرجع القلب ما يقدر يطلع. الليفت فنتريكل فيلير عنده كارديوجينيك شوك. في الليفت فنتريكل ايش يحصل عنده؟ يتجمع سوائل وين؟ في الرئه، يصير عنده شورتنس اوف بريث، ديكريز الكاردياك اوتبوت. يحصل عنده لما تسمع بسماعه في صدره يصير عنده شيء يسميه كراكلز. hypertrophy is different أطياف. So left left ventricles, so all the blood backwards is collected where in the lungs. You get something called rills and crackles in the lung. لما تسمع صدر تسمع زي الشخبطة كأنه يتنفس وفي موية في الرئة، سوائل حول الرئة. So there is some special situation we call it cardiogenic compressive shock from its name compressive. compressive يعني في شيء ضاغط على القلب يسبب لك cardiogenic shock. ايش الحاجات اللي ممكن تعمل كومبريشن على القلب وتعمل لك كارديوجينيك شوك؟ سو تنشن نيوموثوراكس، يكون في هواء تسرب من اللنج حول اللنج ويضغط على اللنج وعلى الرئه داخل الشيست كافيتي داخل الريبس، نسميه تنشن نيوموثوراكس، يضغط على القلب فما يخلي القلب يشتغل زي الناس وما يعدي دم جوا. بريكارديال تامبونادنج، بريكارديال تامبوناد الهارت عليه غلاف اسمه بريكارديوم فايبرس ساك، حاجه زي كيس ابيض مغلف القلب، هذا يتجمعت فيه سوائل بسبب التهاب بسبب طعنه بسبب شيء ويتجمع فيه دم، يسوي كومبريسيف كارديوجينيك شوك، القلب يصير ما يعبي وما يقدر يضخ. ودايفراغماتيك رابشر اند هيرنيا. diaphragmatic rupture usually diaphragm separated the abdomen from the chest. اذا في diaphragmatic rupture معناته لما تاخذ نفس وتطلع نفس الابدومينال كونتنت الستومك والسمول بار والليفر وهذه كلها تطلع في الصدر وتنزل، تطلع في الصدر وتنزل، تعمل كومبريشن على الهارت فما يحصل له pumping وما يحصل له feeling من البلاد ريتيرنز، فيعمل لك cardiogenic shock. So in this slide what you need to know just cardiogenic compressive shock. You need to know tension pneumothorax, pericardial tamponade, diaphragmatic hernia can give you what? Cardiogenic compressive shock. So clinical feature the same as hypovolemic shock. Skin very pale, cold, and clammy. So urine output is low, pulse become rapid and 3D, very weak, and blood pressure is low. Right ventricle dysfunction, you have neck vein distension and liver enlarged, as we said. Left ventricles, we have what? Bronchial rails and third heart sounds. في سوائل في الرئة، وفي بدل ما صوت القلب يصير دقيقتين طق يصير في صوت ثالث برضو عشان السوائل اللي تتجمع في الرئة. And gradually with the time the patient have cardiogenic shock, small heart failure, so the heart became very large. If you do the X-ray you find the heart is very huge inside his chest. يحصل عنده تضخم في القلب. Management cardiogenic shock. How can we manage the cardiogenic shock again? So any management question. So most of the questions coming as a case scenario, guys. So airway must be cleaned. ABC again. Make sure the breathing is good. Put oxygen, include supplemental oxygen, and when systolic pressure is permit, administer IV fluid nitroglycerin to increase the vasoconstriction, and insertion of intrathoracic balloon pump decrease the left ventricular afterload and improving the myocardial performance. So cardiogenic shock a little bit different from the other shock. Why? Because the only shock that we need to give nitroglycerin and intra-aortic balloon pump, swan gas catheter. The only thing we use it for cardiogenic thing. Revascularization with either angioplasty or bypass, and then we see the patient, any patient with cardiogenic shock, most probably they have underlying heart attack. So we send the patient for cardiology and cardiac surgeon, and most of the time they need angioplasty or cardiac bypass CABG لعملية قلب مفتوح عشان restore the blood supply to the cardiac muscles and to relieve the obstruction in the blood vessels. Yes, Atiyaf. So guys, just give me a second.